Good morning. My name is Abigail Davenport, and I'm a Chief Resident at Metro Health Medical Center. Today I'm going to be discussing my research project entitled Effect of Surgical Case Order on Perioperative Outcomes of Total Laparoscopic Hysterectomy for Benign Indications. We have no disclosures to report. Dr. David Shane was the primary investigator for this study, and Caitlin Claridge, one of the other residents at Metro Health, and Alexander Bossia and Nichelle Riffin were co-investigators on this study, and I'd like to thank them for their contributions. Minimally invasive hysterectomy is currently recommended as the standard of care in benign gynecology, and its utilization has increased in recent years. However, minimally invasive techniques require advanced skills and may result in prolonged operating times depending on the surgical indication. Some have speculated that prolonged operating time could result in surgeon fatigue and affect outcomes in cases later in the day. Case length and/or start time have been studied in general surgery, gynecologic oncology, and urogynecology procedures. However, the effect of case start time has not been explored as relates specifically to laparoscopic hysterectomy in the benign literature. The National Surgical Quality Improvement Project, aka NSQIP, is a nationally validated, risk-adjusted, outcomes-based program to measure and improve the quality of surgical care. It collects data on more than 150 peri- and post-operative variables. Data collection is performed by reviewers with standardized training, and Metro Health keeps records of all patients entered into NSQIP. This was a retrospective cohort study utilizing Metro Health data on laparoscopic hysterectomy for benign indications submitted to the NSQIP database between 2010 and 2018. Its objective was to determine whether surgical case order affected complication rates, estimated blood loss, and operating time. CPT codes were used to identify potential study participants, and chart review was used to supplement NSQIP data. Cases with concomitant procedures in addition to hysterectomy were included as long as they were performed by the same surgeon and the primary indication for surgery was uterine or adnexal pathology. Women younger than 18 were excluded as they were not included in NSQIP, and cases preceded by any surgery other than TLH and surgeries for malignant indications were also excluded. Data collection included pre-procedural patient characteristics, intraoperative characteristics, and peri- and post-operative complications. Procedures were stratified into first and second cases. First cases were defined as those performed by a surgeon who had not performed any prior surgery on the day of that TLH, and second cases were defined as those preceded by a TLH performed by the same surgeon who was performing the second case. Pairwise analysis using the Wilcoxon rank sum test or Fisher's exact test were used for data analysis where appropriate, and multivariable regression was used to identify predictors of complication rates, EVL greater than 100 milliliters, and operating time greater than 150 minutes. Table 1 summarizes the pre-procedural, intraoperative, and complication data that we collected. Pre-procedural characteristics included race, age, BMI, smoking status, medical comorbidities, ASA class, hematocrit, sodium, and creatinine. Intraoperative characteristics included surgical indication, operating time, uterine weight, high-volume surgeon or a surgeon with advanced training in minimally invasive techniques, estimated blood loss, and any additional procedures that were performed. Peri- and post-operative complications included transfusion rates, urinary tract injury, intestinal injury, ED visits directly related to the surgery, readmissions, reoperations, and length of hospital stay. "260 cases met study criteria, with 130 cases in each group. First and second cases were well matched with the exception of race and preoperative crit. Second cases were more likely to include patients of non-white race and have a lower preoperative hematocrit. There was no difference in age, smoking status, medical comorbidities, ASA class, or surgical indication. Surgical indications included abnormal uterine bleeding, fibroids, pain, endometriosis, among others. Intraoperative characteristics did not differ in total operating time, uterine weight, or performance by a high-volume surgeon with advanced training. First cases were more likely to include excision of endometriosis, and second cases were more likely to have increased EBL. Transfusion rates, additional procedures, length of stay, and complication rates did not differ between the two groups. Independent risk factors for increased blood loss and operating time included surgery for fibroids, second case, and BMI. Independent risk factors for increased operating time included lysis of adhesions, sling placement, and uterine weight. Surgeries performed by a high-volume surgeon were associated with decreased operating time. Table 2 describes the preoperative characteristics of study participants, and we can see here that second start cases were more likely to have participants of non-white race and also to have a lower preoperative hematocrit. Table 3 describes the intraoperative characteristics, and here we can see that estimated blood loss was higher in second start cases, and excision of endometriosis was higher in first start cases. Table 4 describes the complication rates. Here we can see that there was no difference in the complication rates described in this table for first or second start cases. Table 5 describes the multivariable logistic regression models of independent risk factors for increased blood loss and operating time. Surgeries for fibroids, second case, and increased body mass index all had a higher odds ratio for intraoperative blood loss greater than 100. And the risk of operating time greater than 150 minutes was higher in cases with lysis of adhesions, sling placement, or higher uterine weight, whereas surgeries performed by a high-volume surgeon tended to have a shorter operating time. The effective case start time on complication rates has not yet been explored in the literature in regards to TLH for benign indications. In our study, there was no difference in complication rates between first and second cases. While second cases had a greater EBL, there was no difference between the two groups in transfusion rates, and thus this difference is likely not clinically significant. Risks for EBL greater than 100 milliliters included surgery for fibroids, second case start, and a higher BMI. The strengths of this study included the use of a well-studied and standardized database and a large sample size, while weaknesses included single institution data and a retrospective design. Future research could prospectively examine complication rates at multiple institutions to mitigate some of these weaknesses. Thank you.